Hello, and welcome back to another stream of Advanced Pharmacology. Today we're talking about Chapter 35. Chapter 35 deals with diuretics. Diuretics have two major applications: the treatment of hypertension and the mobilization of edematous fluid associated with heart failure, cirrhosis, or kidney disease. In addition, because of their ability to maintain urine flow, diuretics are used to prevent renal failure. So we'll do a quick review of the renal anatomy and physiology. Understanding that diuretic drugs require a basic knowledge of anatomy and physiology of the kidneys. Therefore, let's review the topics before discussing the diuretics themselves. The anatomy. The basic function of the kidney is the nephron. As indicated here in the following figure, the nephron has four functions that are in distinct regions: the glomerulus, the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule. All nephrons are oriented with the kidney such that the upper portion of the loop of Henle is located in the renal cortex, and the lower end of the loop descends towards the renal medulla. Without this orientation, the kidney could not produce concentrated urine. In addition to the nephrons, the collecting ducts play a critical role in kidney function. The final segment of the distal convoluted tubule, plus the collecting ducts into which it empties, can be considered a single functional unit, the distal nephron. So, looking at the physiology, the overview. The kidneys serves three basic functions: cleansing of extracellular fluid and maintaining of ECF volume and composition, maintenance of acid-base balance, and finally the excretion of metabolic wastes and foreign substances. Of the three, maintenance of your extracellular fluid, volume, and composition is one of the ones that the diuretics affect most. The three basic renal processes. Effects of the kidney on the extracellular fluid, or ECF, are the net results of three basic processes: filtration, reabsorption, and active secretion. To cleanse the entire ECF, a huge volume of plasma must be filtered. Furthermore, to maintain homeostasis, practically everything that has been filtered must be reabsorbed, leaving behind only a small volume of urine for excretion. So, speaking on filtration on its own, filtration occurs at the glomerulus and is the first step in urine formation. Virtually all small molecules, your electrolytes, amino acids, glucose, drugs, and metabolic wastes that are present in plasma undergo filtration. In contrast, cells and large molecules, your lipids and proteins, remain behind in the blood. The most prevalent constituents of the filtrate are sodium ions and chloride ions. Bicarbonate ions and potassium ions are also present, but in much smaller amounts. The filtration capacity of the kidney is very large. Each minute the kidney produces 125 ml of filtrate, which adds up to 180 liters per day. Because the total volume of ECF is only 12.5 liters, the kidneys can process the equivalent of all the ECF in the body every 100 minutes. Therefore, the ECF undergoes complete cleansing about 14 times each day. Be aware that filtration is the non-selective process and therefore cannot regulate the composition of urine. Reabsorption and secretion, processes that display a significant degree of selectivity, are the primary determinants of what the urine ultimately contains. Of the two, reabsorption is by far the more important one. Which, speaking of reabsorption, more than 99% of water, electrolytes, and nutrients that are filtered at the glomerulus undergo reabsorption. This conserves valuable constituents of the filtrate while allowing wastes to undergo excretion. Reabsorption of solutes, your electrolytes, amino acids, and glucose, take place by the way of an active transport. Water then follows passively along the osmotic gradient created by solute reuptake. Specific sites along the nephron at which reabsorption takes place are discussed later. Diuretics work primarily by interfering with reabsorption. The active tubular secretion. The kidney has two kinds of pumps for active secretion. These pumps transport compounds from the plasma into the lumen of the nephron. One pump transports organic acids and the other transports organic bases. Together, these pumps can promote the excretion of a wide assortment of molecules, including metabolic waste, drugs, and toxins. The pumps for active secretion are located in the proximal convoluted tubule. So, processes of reabsorption that occur at specific sites along the nephron. Because most diuretics act by disrupting the solute reabsorption, to understand the diuretics, we must first understand the major processes by which nephrons reabsorb filtered solutes. Because sodium and chloride ions are the predominant solutes in the filtrate, reabsorption of these ions is of greatest interest. As we discuss reabsorption, numeric values are given for the percentage of solutes reabsorbed at specific sites along the nephron. Bear in mind that these values are only approximate. The following figure here depicts the sites of the sodium and chloride reabsorption, indicating the amount of reabsorption that occurs at each site. So here you're taking a look at the schematic diagram of a nephron, showing sites of sodium absorption and diuretic action. The proximal convoluted tubule. The proximal convoluted tubule, or PCT, has the high reabsorptivity capacity. A large fraction, about 65%, of filtered sodium and chloride is reabsorbed at the PCT. In addition, essentially all of the bicarbonate and potassium in the filtrate is reabsorbed here. As sodium, chloride, and other solutes are actively reabsorbed, water follows passively. Because solutes in water are reabsorbed to an equal extent, the tubular urine remains isotonic, about 300 mosm. By the time the filtrate leaves the PCT, sodium and chloride are the only solutes that remain in significant amounts. The loop of Henle. The descending limb of the loop of Henle is freely permeable to water. Therefore, as tubular urine moves down the loop and passes through the hypertonic environment of the renal medulla, water is drawn from the loop into the interstitial space. This process decreases the volume of the tubular urine and causes the urine to become concentrated. Within the thick segment of the ascending limb of the loop of Henle, about 20% of sodium chloride is reabsorbed. Because, unlike the descending limb, the ascending limb is not permeable to water. Water must remain in the loop as reabsorption of sodium chloride takes place. This process causes the tonicity of the tubular urine to return to that of the original filtrate, at 300 mosm. That takes us to the distal convoluted tubule, which is an early segment. About 10% of filtered sodium and chloride is reabsorbed in the early segment of the distal convoluted tubule. Water follows passively here. In the distal nephron, with a late distal convoluted tubule and collecting duct, the distal nephron is the site of two important processes. The first involves exchange of sodium for potassium and is under the influence of aldosterone. The second determines the final concentration of urine and is regulated by antidiuretic hormone, or ADH. Although sodium-potassium exchange is discussed in more detail, we will not continue discussing of ADH because it has little to do with the actions of diuresis. The sodium-potassium exchange, aldosterone, the principal mineral or corticoid of the adrenal cortex, stimulates reabsorption of sodium from the distal nephron. At the same time, aldosterone causes potassium to be secreted. Although not directly coupled, these two processes, sodium retention and potassium excretion, can be viewed as an exchange mechanism. This exchange is shown in Figure 35.2. Aldosterone promotes sodium-potassium exchange by stimulating cells of the distal nephron to synthesize more of the pumps responsible for sodium and potassium transport. So some of the drugs we'll be discussing are loop diuretics, thiazide diuretics, and your potassium-sparing diuretics. So, the introduction to diuretics. How do diuretics work? Most diuretics share the same basic mechanism of action, the blockade of sodium and chloride reabsorption. By blocking the reabsorption of these prominent solutes, diuretics create osmotic pressure within the nephron that prevents the passive reabsorption of water. Therefore, diuretics cause water and solutes to be retained within the nephron and thereby promote the excretion of both. The increase in urine flow that a diuretic produces is directly related to the amount of sodium and chloride reabsorption that it blocks. Accordingly, drugs that block solute reabsorption to the greatest degree produce the most profound diuresis. Because the amount of solute in the nephron becomes progressively smaller as filtrate flows from the proximal tubule to the collecting duct, drugs that act early in the nephron have the opportunity to block the greatest amount of solute reabsorption. As a result, these agents produce the greatest diuresis. Conversely, because most of the filtered solid has already been reabsorbed by the time the filtrate reaches the distal part of the nephron, diuretics that act at distal sites have very little reabsorption available to block. Consequently, such agents produce relatively scant diuresis. It is instructive to look at the quantitative relationship between the blockade of solid reabsorption and the production of diuresis. Recall that the kidney produces 180 liters of filtrate a day, practically all of which is normally reabsorbed. With filtrate production at this volume, a diuretic will increase daily urine output by 1.8 liters for each 1% of solute reabsorbed that is blocked. A total of 3% of the blockage of a solute reabsorption will produce 5.4 liters of urine a day, a rate of fluid loss that would reduce body weight by 12 pounds in 24 hours. Clearly, with only a small blockade of reabsorption, diuretics can produce a profound effect on the fluid and electrolyte composition of the body. So, adverse impacts on extracellular fluid. To promote excretion of water, diuretics must interfere with the normal operation of the kidney. By doing so, diuretics can cause hypovolemia, acid-base imbalances, and altered electrolyte levels. These adverse effects can be minimized by using short-acting diuretics and by timing drug administration such that the kidney is allowed to operate in a drug-free manner between periods of diuresis. Both measures will give the kidney periodic opportunities to readjust the ECF to compensate for any undesired alterations produced under the influence of diuretics. The classification of diuretics. There are four major categories of diuretic drugs: loop diuretics, thiazide diuretics, and osmotic diuretics, and potassium-sparing diuretics. The last group, the potassium-sparing agents, can be subdivided into aldosterone antagonists and non-aldosterone antagonists. In addition to the four major categories of diuretics, there is a fifth group, the carbonic anhydrase inhibitors. Although the carbonic anhydrase inhibitors are classified as diuretics, these drugs are employed primarily to lower intraocular pressure and not to increase urine production. Consequently, the carbonic anhydrase inhibitors will be discussed in Chapter 84. So, loop diuretics. The loop agents are the most effective diuretics available. These drugs produce more loss of fluid and electrolytes than any other diuretic. They are known as loop diuretics because their site of action is in the loop of Henle. The first of which is furosemide, or Lasix, which is most frequently prescribed loop diuretic and will serve as our prototype for this group. Its mechanism of action. Lasix acts in the thick segment of the ascending limb of the loop of Henle to block reabsorption of sodium and chloride. But by blocking solute reabsorption, Lasix prevents passive reabsorption of water. Because substantial amount, about 20% of filtered sodium chloride is normally reabsorbed in the loop of Henle, interference with the reabsorption here can produce profound diuresis. Its pharmacokinetics. With oral administration, diuresis begins in 60 minutes and can persist for up to 8 hours. Oral therapy is used when rapid onset is not required. Furosemide undergoes hepatic metabolism followed by renal excretion. Its therapeutic use. Lasix is a powerful drug that is generally reserved for situations that require rapid or massive mobilization of fluid. This drug should be avoided when less efficacious diuretics will suffice, such as thiazides. Conditions that justify the use of Lasix may include pulmonary edema associated with congestive heart failure, edema of hepatic, cardiac, or renal origin that has been unresponsive to less efficacious diuretics, and hypertension that cannot be controlled with other diuretics. Lasix is especially useful in patients with severe renal impairment because, unlike thiazides, the drug can promote diuresis even when renal blood flow and glomerular filtration rate are low. If treatment with Lasix alone is insufficient, a thiazide diuretic may be added to the regimen. There is no benefit to combining Lasix with any other type of loop diuretic. It does, however, have adverse effects: hyponatremia, hypochloremia, and dehydration. Lasix can produce excessive loss of the three major sections here: sodium, chloride, and water. Severe dehydration can result. Signs of evolving dehydration include dry mouth, unusual thirst, and oliguria. Impending dehydration can also be anticipated from excessive loss of weight. If dehydration occurs, Lasix should be withheld. The risk for dehydration and its sequelae can be minimized by initiating therapy with low doses, adjusting the dosage carefully, and monitoring weight every day. Hypotension. Lasix can cause substantial drop in blood pressure. At least two mechanisms are involved: the loss of volume and the relaxation of venous smooth muscle, which reduces venous return to the heart. Signs of hypotension include dizziness, lightheadedness, and fainting. If blood pressure falls precipitously, Lasix should be discontinued. Because of the risk for hypotension, blood pressure should be monitored routinely. Patient education on hypotension. Patients should be taught to monitor their blood pressure and be instructed to notify the prescriber if it drops substantially. Also, patients should be informed about the symptoms of postural hypotension and be advised to sit or lie down if these occur. Patients should be taught that postural hypertension can be minimized by rising slowly. Hypokalemia. Potassium is lost through increased secretion in the distal nephron. If potassium falls below 3.5, fatal dysrhythmias may result. As discussed later under drug interactions, the loss of potassium is a special concern for patients taking digoxin, a drug for heart failure. Hypokalemia can be minimized by consuming potassium-rich foods, taking potassium supplements, or using a potassium-sparing diuretic. Ototoxicity. Rarely, loop diuretics cause hearing impairment. With Lasix, deafness is transient. With ethacrynic acid, another loop diuretic, irreversible hearing loss can occur. The ability to impair hearing is unique to the loop diuretics. Diuretic, Diuretics and other classes are not ototoxic. Because of the risk for hearing loss, caution is needed when loop diuretics are used in combination with other ototoxic drugs, such as your aminoglycoside antibiotics. Hyperglycemia. Its evaluation of plasma glucose is a potential, albeit uncommon, complication of Lasix therapy. Hyperglycemia appears to result from the inhibition of insulin release, increased glycogenolysis, and a decreased glycogen synthesis may also contribute. When Lasix is taken by a diabetic patient, he or she should be especially diligent about monitoring blood glucose content. Hyperuricemia. Elevation of plasmic uric acid is a frequent side effect of treatment. For most patients, Lasix-induced hyperuricemia is asymptomatic. However, for patients predisposed to gout, elevation of uric acid may precipitate a gouty attack. Patients should be informed about symptoms of gout and be instructed to notify the prescriber if these develop. The use in pregnancy. When administered to a pregnant laboratory animal, loop diuretics have caused maternal death, abortion, fetal resorption, and other adverse effects. There are no definitive studies on loop diuretics during human pregnancy. However, given the toxicity displayed in animals, prudence dictates that pregnant patients use these drugs only if absolutely necessary. So here is a patient-centered care across the lifespan on diuretics. You can hit pause here and take a look at them. Impacts on lipids, magnesium, and calcium. Lasix reduces high-density lipoprotein, your HDL, cholesterol, and raises low-density lipoprotein, your cholesterol and triglycerides. Although these undesirable effects by themselves can increase the risk for coronary heart disease, they are more than balanced by the beneficial effects of the diuretic therapy on the heart. That is, despite adverse effects on lipids, loop diuretics reduce the risk for coronary mortality by 25%. Lasix increases urinary excretion of magnesium, posing a risk for magnesium deficiency. Symptoms include muscle weakness, tremors, twitching, and dysrhythmias. Lasix increases urinary excretion of calcium. This action has been exploited to treat hypercalcemia. Drug interactions with digoxin, however, in the presence of low potassium, the risk for serious digoxin-induced toxicity is greatly increased, causing ventricular dysrhythmias. Because loop diuretics promote potassium loss, use of the drugs in combination with digoxin can increase the risk for dysrhythmia. This interaction is unfortunate in that most patients who take digoxin for heart failure also are usually on a diuretic. To reduce the risk for toxicity, potassium levels should be monitored routinely, and when indicated, potassium supplements or a potassium-sparing diuretic ought to be given. Ototoxic drugs. The risk for Lasix-induced hearing loss is increased by concurrent use of other ototoxic drugs, especially your aminoglycoside antibiotics, gentamicin, for example. Accordingly, combined use of these drugs should be avoided. Your potassium-sparing diuretics, such as your spironolactone or triamterene, can help counterbalance the potassium-wasting effects of Lasix, thereby reducing the risk of hypokalemia. Lithium. In patients with low sodium, excretion of lithium is also reduced. Therefore, by lowering sodium levels, Lasix can cause lithium to accumulate to toxic levels. Accordingly, lithium levels should be monitored, and if they climb too high, a lithium dosage should be reduced. Antihypertensive agents. The hypotensive effects of Lasix add with those of other hypotensive drugs. To avoid excessive reduction of blood pressure, patients may need to reduce or eliminate use of other hypotensive agents. Your NSAIDs, aspirin and other NSAIDs can attenuate the diuretic effect of Lasix. The mechanism appears to be the inhibition of prostaglandin synthesis in the kidney. Part of the diuretic effect of Lasix results from increasing renal blood flow, which is thought to occur through the prostaglandin-mediated process. By inhibiting prostaglandin synthesis, NSAIDs prevent the increase in renal blood flow and thereby partially blunt the diuretic effect. So, other loop diuretics. In addition to Lasix, there are 3 loop diuretics that are currently available: urethrocrinic acid, torsemide, and Bumex. All 3 are much like Lasix. They all promote diuresis by inhibiting sodium and chloride reabsorption in the thick ascending limb of the loop of Henle. All are approved for edema caused by heart failure, chronic renal disease, and cirrhosis. But only torsemide, similar to Lasix, is also approved for hypertension. Keep in mind, all of these can cause ototoxicity, hypovolemia, hypotension, hypokalemia, hyperuricemia, hyperglycemia, and the disruption again of the lipid metabolism, specifically the reduction of HDL cholesterol and the elevation of LDL cholesterol and triglycerides. Lastly, they all share the same drug interactions. Their effects can be blunted by NSAIDs. They can intensify ototoxicity caused by aminoglycosides, and they can increase cardiotoxicity caused by digoxin. They can also cause lithium to accumulate to toxic levels. So, the following table here is a good spot to hit pause so you can see the dosage and time courses. Again, the black box warning for all loop diuretics mean that all loop diuretics can cause profound diuresis with water and electrolyte depletion. Which brings us to thiazides and their related diuretics. Thiazides and thiazide diuretics have effects similar to those of loop diuretics. Like the loop diuretic, thiazides increase renal excretion of sodium, chloride, potassium, and water. In addition, thiazide elevate a plasma level of uric acid and glucose. The principal difference between the thiazide and the loop diuretic is that the maximal diuresis produced by the thiazide is considerably lower than the maximal diuresis produced by the loop diuretic. In addition, whereas loop diuretics can be effective even when urine flow is decreased, thiazides cannot. So, hydrochlorothiazide, or HCTZ, is the most widely used thiazide diuretic and will serve as our prototype for the group. Because of its use in hypertension, hydrochlorothiazide is one of our most widely used drugs. Its mechanism of action promotes urine production by blocking the reabsorption of sodium and chloride in the early segment of the distal convoluted tubule. Retention of sodium and chloride in the nephron causes the water to be retained as well, thereby producing an increased flow of urine. Because only 10% of filtered sodium and chloride is normally reabsorbed at the site where the thiazide acts, the maximal urine flow these drugs can produce is lowered than with the loop diuretic. The ability of thiazides to promote diuresis is dependent on adequate kidney function. These drugs are ineffective when you have a low GFR. Therefore, in contrast to a loop diuretic, thiazides cannot be used to promote fluid loss in patients who have severe renal failure or renal impairments. Its pharmacokinetics. Diuresis generally begins about 2 hours after oral administration. Its effects peak within 4 to 6 hours and may persist up to 12 hours. Most of the drug is excreted unchanged in urine. Again, here's a good spot to hit pause so that you can see the different thiazides and their related diuretics. You can see their dosages and time course of effects. Its therapeutic use, therefore. Hydrochlorothiazide is essential in the treatment for hypertension. The primary indication for hydrochlorothiazide is hypertension, a condition in which the thiazides are often drugs of first choice. For many hypertensive patients, blood pressure can be controlled with a thiazide alone, although many other patients require multi-drug therapy. The role in thiazide and hypertension is going to be discussed in further detail in Chapter 39. Edema. Thiazides are preferred drugs for mobilizing edema associated with mild to moderate heart failure. They are also given to mobilize edema associated with hepatic or renal disease. Its protection against postmenopausal osteoporosis. Thiazides promote tubular reabsorption of calcium and may thereby decrease the risk for osteoporosis in a postmenopausal woman. Here's how. Before menopause, estrogen from the ovaries act on renal tubules to promote calcium reabsorption. When menopause occurs, however, those estrogen levels drop, allowing renal excretion of calcium to increase. The resultant decrease in circulating calcium promotes mobilization of calcium from the bone and thereby increases the risk for osteoporosis. Now here's where thiazide kicks in. Because thiazide promotes renal calcium retention, they may counteract the calcium loss associated with menopause and may thereby help preserve bone integrity. However, it has adverse effects. Thiazide diuretics are similar to those of loop diuretics, in fact, with the exception that a thiazide cannot cause ototoxicity. The adverse effects of a thiazide and loop diuretic are nearly identical. So you'll see the hyponatremia, hypochloremia, and dehydration. The loss of sodium, chloride, and water can lead to hyponatremia, hypochloremia, and dehydration. However, because the diuresis produced by a thiazide is moderate, these drugs have a similar effect on sodium, chloride, and water than do the loop diuretics. To evaluate fluid and electrolyte status, electrolyte levels should be determined periodically, and the patient should be weighed on a regular basis. Hypokalemia. The loop diuretic, the thiazide can cause hypokalemia from excessive potassium excretion. Again, as noted, potassium loss is of a particular concern for patients taking digoxin. Potassium levels should be measured periodically, and if the serum potassium falls below 3.5, treatment with a potassium supplement or a potassium-sparing diuretic should be instituted. Hypokalemia can be minimized by having a potassium-rich diet. Hyperglycemia. Like the loop diuretics, the thiazides can elevate plasma levels of glucose. Significant hyperglycemia develops only in diabetic patients, who should be especially diligent about monitoring their blood sugar. To maintain normal glucose levels, a diabetic patient may require a larger dose of insulin or an oral hypoglycemic drug. Hyperuricemia. Again, the thiazides, like the loop diuretics, can cause that retention of uric acid, thereby elevating plasma uric acid. Although hyperuricemia is usually asymptomatic, it can precipitate gouty arthritis in patients that have that history. Plasma levels of uric acid should be measured periodically. Impacts on your lipids and magnesium. So again, thiazides can increase levels of LDL cholesterol, total cholesterol, and triglycerides. Thiazides increase excretion of magnesium, sometimes causing a magnesium deficiency. So symptoms of a low magnesium level include weakness, tremors, twitching, and again, fatal dysrhythmias. Your drug interactions. The most important drug interaction of thiazides are those identical to that of a loop diuretic. By promoting potassium loss, thiazides can increase the risk of toxicity from digoxin. By lowering your blood pressure, thiazides can augment the effects of other antihypertensive drugs. By promoting sodium loss, thiazides can reduce renal excretion of lithium and can cause the drug to accumulate to, again, possible toxic levels. Again, NSAIDs may stunt or have blunt effects on diuretics, including that of thiazide. By counterbalancing the potassium wasting effects of the thiazide, the potassium-sparing diuretics that can help prevent excessive potassium loss. In contrast to loop diuretics, you can use thiazides with medications that are ototoxic without increasing the risk for hearing loss. Which leads us to the potassium-sparing diuretics. Potassium-sparing diuretics can elicit two potentially useful responses. First, they produce a modest increase in urine production. Second, they produce a substantial decrease in potassium excretion. Because their diuretics effects are limited, the potassium-sparing drugs are rarely employed alone to promote diuresis. However, because of their marked ability to decrease potassium excretion, these drugs are often used to counteract potassium loss caused by medications such as your loop diuretics and your thiazides. There are two subcategories of potassium-sparing diuretics, your aldosterone antagonists and your non-aldosterone antagonists. In the US, only one aldosterone antagonist, your aldactone, is used for diuresis. There are two non-aldosterone antagonists, triamterene and amiloride, and both are currently used, though I would say rarely. We'll start with aldactone, or spironolactone. It works in the following manner. It blocks the action of aldosterone in the distal nephron. Because aldosterone acts to promote sodium uptake in exchange for potassium secretion, inhibition of aldosterone has the opposite effect. By providing the retention of potassium, it increases the excretion of sodium. The diuresis caused by aldactone is scanty because most of the filtered sodium load has already been reabsorbed by the time the filtrate reaches the distal nephron. The effects of aldactone are also delayed, taking up to 48 hours to develop. Recall that aldosterone acts by stimulating cells of the distal nephron to synthesize the proteins required for sodium and potassium transport. By preventing aldosterone's action, aldactone blocks the synthesis of new proteins, but does not stop existing transport proteins from doing their job. Therefore, effects are not visible until the existing proteins complete their normal life cycle, which can take 1 to 2 days. Aldactone has a black box warning that shows that it can be a tumorigenic in rats, so avoid unnecessary use. The following table here is a good spot to hit pause so you can see the name, dosage, and the time course for effects of all potassium-sparing diuretics. So, its therapeutic use, hypertension and edema. Aldactone is used primarily for hypertension and edema. Although it can be employed alone, the drug is used most commonly in combination with a thiazide or loop diuretic. Again, the purpose of aldactone is in these combinations to counteract the potassium wasting effect of the more powerful diuretic. Aldactone also makes a small contribution to diuresis if given in monotherapy. Aldactone can be used in heart failure. In patients with severe heart failure, aldactone reduces mortality and hospital admissions. Benefits derived from protective effects of aldosterone blockade in the heart and blood vessels are going to be discussed in closer detail in Chapter 40. However, aldactone has adverse effects. Again, hyperkalemia. Because potassium-sparing effects of aldactone can result in hyperkalemia, a condition that is just as fatal as hypokalemia and can cause a fatal dysrhythmia. Although hyperkalemia is most likely when spironolactone or aldactone is used in monotherapy, it can also develop when spironolactone is used in conjunction with a potassium wasting agent. So, if your potassium levels rise above 5 MEq per liter, or if there are signs of hyperkalemia developing, again, that abnormal heart rhythm, aldactone or spironolactone should be discontinued and a potassium intake ought to be restricted. It also has effects on the endocrine system. Aldactone is a steroid derivative with a structure similar to that of steroid hormones, your progesterone, estradiol, and testosterone. So as a result, aldactone can cause a variety of endocrine effects, including gynecomastia, menstrual, menstrual irregularities, impotence, hirsutism, and a deepening of the voice. So, benign and malignant tumors are also associated again in rats. So, in doses 25 to 250 times those used in humans, aldactone may cause benign adenomas of the thyroid and testes, malignant mammary tumors, and a proliferative change in the liver. The risk for having a tumor in humans from use of normal dosage, however, is considered unknown and considered low. Drug interactions, thiazide and loop diuretics. Because spironolactone is frequently used in combination with a thiazide and loop diuretic, the goal is to counteract the potassium wasting effect of the more powerful diuretic. However, agents that raise potassium levels, because there is that risk for hyperkalemia, caution must be employed when combining aldactone with potassium supplements, salt substitutes, and other potassium-sparing diuretics. In addition, 3 groups of drugs, your angiotensin-converting enzymes, your ACE inhibitors, angiotensin receptor blockers, and direct renin inhibitors, can elevate potassium levels, and therefore should be combined with aldactone only when clearly necessary. So, use with caution. Your triamterene, its mechanism of action. Like aldactone, triamterene disrupts sodium-potassium exchange in the distal nephron. However, in contrast to aldactone, which reduces ion transport indirectly through the blockade of aldosterone, triamterene is a direct inhibitor of the exchange mechanism by itself. The net effect of inhibition is a decrease in sodium reabsorption and a reduction in potassium secretion. Therefore, sodium excretion is increased while potassium is conserved. Because it inhibits ion transport directly, triamterene acts much more quickly than aldactone. The initial response develops in a couple hours. Again, aldactone had that same mechanism of action, but it took several days. It said 1 to 2 days. So, the diuresis with triamterene, however, is also minimal. Its therapeutic use can be used alone or in combination with other diuretics to treat hypertension and edema. When used alone, however, triamterene produces only mild diuresis. When combined with other diuretics, again your Lasix, your HCTZ, triamterene augments diuresis and helps counteract that potassium wasting effect of the more powerful diuretic. It is the latter effect for which triamterene is principally employed. Again, it has adverse effects. Because of how it works, it can cause hyperkalemia. Excessive potassium accumulation is the most significant adverse effect. Hyperkalemia is the most likely when triamterene is used alone, but can also occur when the drug is combined with a thiazide or loop diuretic. Caution should be employed when triamterene is used in conjunction with any other potassium-sparing diuretic, or with, again, potassium supplements or salt substitutes. Again, in addition, caution is needed if the drug is combined with an ACE inhibitor, angiotensin receptor blocker, or a direct renin inhibitor. So it's black box warning for triamterene as well as for amiloride can carry the risk for hyperkalemia that is potentially fatal if left uncorrected. We must monitor our potassium levels at the start, at the dose changes, and during illness that could affect renal function. So 3 different times that we would make sure that we are checking our potassium levels. Other adverse effects. Relatively common side effects include nausea, vomiting, leg cramps, and dizziness. Blood dyscrasias can occur, but rarely. Which brings us to our last medication, amiloride. Amiloride, the pharmacologic property, has similar action to that of triamterene. Both drugs inhibit potassium loss by direct blockade of sodium-potassium exchange in the distal nephron. Also, both drugs produce only a modest diuresis. Although it can be employed alone as a diuretic, amiloride is used primarily to counteract potassium loss caused by more powerful diuretics, again, that thiazide and loop diuretic. The major adverse effect, again, is hyperkalemia. Accordingly, concurrent use of other potassium-sparing drugs or potassium supplements must be monitored closely. Caution is needed if the drug is combined with an ACE inhibitor, an angiotensin receptor blocker, or a direct renin inhibitor. And that concludes this chapter here for today. I thank you for listening as always, and I'll see you at the next chapter. Till then, have a wonderful day.